Chair Fergus, the meeting is yours.
All righty, wonderful. Thank you, everybody, for joining us today and bearing with us while we secured a quorum. And with that, Valerie, I'll call the meeting to order now at 12:06 of the Rural Regional Behavioral Health Policy Board for February 5th, 2025. And Valerie, if you could please just run through the roll call as you have it,
Okay.
in case we missed anybody.
Chair Fergus Lothridge.
Present.
Brooke O'Byrne. Senator Pete Goycochea is no longer a member of the board, so that does need to be edited. He has been replaced with Senator John Ellison. However, all legislators are statutorily excused from board meetings during the legislative session. Dr. Erica Rist.
Present.
Matt Walker.
Yep, here.
Amanda Osborne. Chris McCann.
Present.
Patrick Rogers is excused. Sarah Dearborn.
I'm here.
Bryce Shields. And Jerry Sanders.
Here.
All right, thank you, Chair Fergus Lothridge. We have maintained a quorum.
Very good. Thank you, everyone. Let's jump right to item 2. Keep this thing moving in the interest of everyone's time. Item 2 is public comment. If we could limit your comments to not more than 3 minutes. I believe there were a couple that had already posted something in chat that they wanted to have a few words. So I'll open it up for public comment.
Yep, so Marianne McCown.
Hi, so I'm Marianne McCown. I'm from Vitality Unlimited and I do the outreach for Vitality. Vicki Laversa, who is our Eastern Nevada Behavioral Health Operations Coordinator, wanted to give the board a little bit of information on some issues we've had with licensing boards. We understand that the boards can't really do anything, but we still think it's information that you guys could be useful to the boards, especially with different legislative bills that are coming up. So I'll let Vicki tell you some of the issues.
Okay, thank you very much, Marianne. Our internet is somewhat unstable, so hopefully this won't cut out. Questions you can certainly reach out. As Marianne said, I'm Vicki Laversa. I'm the Eastern Nevada Program Coordinator with Vitality Unlimited. And as all of you probably know, it's very difficult to maintain a workforce here in the Elko area. One of the things that is a concern for me in working with the board that I'm currently licensed, we have a board of alcohol and drug counselors and problem gambling, is the restrictions that the board places. So for instance, in the last 2 months, I've had 2 people apply for internships that were experienced. One was certified through the state of Arizona, had 10 years of experience, and was advised by our board that the only way that they could practice would to become an intern again, but could only work with the Native American population. And so, of course, that strictly prohibits what we're available to do. We also had a gentleman apply that is going through the appeal process and recognizing that he didn't submit the paperwork in what they considered a timely manner. And I just wanted to bring it to your attention that not only are we struggling with maintaining, but I think there's some barriers here that we need to address through the boards. And I know that you're looking at whether it be the MFT board, CBC, social work board. It's not just those. There's some other boards that need to be involved. And just wanted to give you a little piece of experience of what we're seeing, so that when you go forward, you'll have more information. Thank you.
Vicki, your audio cut in and out there a few times. It might be because of your internet. What I sense is that there was you had two two people that were applying for internships and they were denied or something of that matter. If you could put those some details to writing for us, communicate those to Valerie Haskins, and we will then be able to have that in front of us as we meet with the various licensing board directors. We'd see about following up on that.
Becky, you're still muted.
I will draw up a summary and give it to Valerie. Absolutely.
Terrific. Thank you so much. Other public comment?
You're welcome. Thank you.
Chair Sarah Dearborn has her hand raised.
Sarah, go ahead.
Thank you so much. For the record, my name is Sarah Dearborn. I am the Chief over our medical, dental, and behavioral health benefits coverage policies at Nevada Medicaid. So I'll try to make this short and sweet, but also want to know, Valerie, am I able to put the link to our public notice webpage in the chat, or should I email that to you to send out?
Let's email that out. The chat is not supposed to be a part of public record, so we do want to avoid using that.
That's what I thought, but wanted to clarify. So I will definitely provide Valerie the link to our public notice website, but really wanted to call attention to some upcoming important dates and public workshops and hearings that Nevada Medicaid will be providing related to behavioral health policy updates. So there will be a public workshop coming February 12th. And these policy updates will be within Medicaid Service Manual Chapter 400. These policy updates relate to our designated mobile crisis team policy, where we'll be removing the requirement for a peer to be required as part of the team on a DMCT. Also, we will be removing the requirement to have a certification through the Division of Public and Behavioral Health as a designated mobile crisis team. That certification has not been developed yet. So we are removing that requirement in hopes to get some more involved providers under that Medicaid specialty. So that public workshop again is coming February 12th. The following day, on February 13th, we will also be hosting an additional public workshop on one of our newer chapters of policy. That's Medicaid Service Manual Chapter 4100. And this chapter is really specific to our substance use treatment provider types. And we'll be updating policy, hopefully clarifying some language around the services that are included in our residential SUD levels of care, to include not strictly just clinical services, but also structured services that have been identified by the clinical staff as necessary as part of the program. Also want to call attention to our two upcoming public hearings. Public hearings are when Medicaid presents and proposes updates to officially submit or approval either through administration or to submit to our federal partners at the Centers for Medicare and Medicaid Services. So the next two public hearings, one being February 25th, and then the next one will be March 25th. They are very busy. February 25th, we'll be presenting updates on MSM 400 around peer service limitations, and this is really specific to our provider type 14 outpatient behavioral health treatment providers, where we'll be aligning service limitations with our substance use treatment providers. So an individual, a Medicaid eligible individual would be able to receive up to 18 hours of peer services prior to a prior authorization being required. Also, we'll be presenting some updates around our partial hospitalization policy as well as our intensive outpatient policy. You don't have to quickly write all this down. Again, all these edits will be posted where you can find them on the public notice website. But really also want to call attention to our March 25th public hearing. We have whole lot of behavioral health policy updates coming to that. The first, we will be proposing some new behavioral health outpatient rate increases. And so that's really exciting. Behavioral health hasn't seen rate increases for quite some time, so we're excited to propose those. Those, of course, have to go move through our federal process as well, but we do plan to do kind of a semi-public workshop just to present what our proposed rates will be to inform providers. Also, at that March 25th public hearing, we will also be presenting updates to our state plan to include services for eligible in juveniles for targeted case management services that are required under the Consolidated Appropriations Act of 2023. So this permits Medicaid eligibility 30 days pre-release of a carceral facility and then 30 days post-release as well. So that's really exciting stuff moving forward. I will be sure to email that public notice post. Additionally, I just want to mention, I told Valerie I'd let her know too, Medicaid's doing a whole lot of work on our crisis services around really revising our mobile crisis rate methodology to account for a more comprehensive 24/7, 365 mobile crisis team response. But also there's a lot of development around our facility-based crisis stabilization services. So currently Medicaid reimburses for a hospital that holds an endorsement as a crisis stabilization center. We reimburse at a daily rate for that. So that is open to interested providers, but we will also be developing a community facility-based provider of intensive crisis stabilization services. So again, similar to a crisis stabilization center, but this provider type would not require that hospital endorsement. Right now we're in development. Yes.
Sarah, we're over our 3 minute
Got it.
point. And need you, if you could put that in a summary and get that to Valerie, and she can get it out to both our board members and her distribution list for those that are on this call. And
Sure,
she
I
can turn
can
that
do
around
that.
pretty quickly for you.
Thank you.
Great. Other public comment, please. Sorry to have to cut folks off, but interest of time, we have to keep this thing moving. Next will be our item number 3, which will be the review and approval of meeting minutes from our October 4th, 2024 meeting. I'll entertain a motion from members of the board. You've had a chance to review that and would entertain a motion.
Chair Lawfridge, I will make a motion to approve the minutes.
Motion by Dr. Riss. Is there a second? Anybody? Matt?
This is Sarah, I second.
Okay. We have a motion and a second, and all those in favor say aye, or any opposed, please indicate now. Okay. Thank you. Let's move this on so that Valerie can get those posted up as approved, and we'll move to item number 4, trying to speed things up here a little bit. Let's touch on our 2025 meeting schedule so we can get that on our calendars and plan accordingly. Valerie, I'll turn this over to you.
All right, everyone. So during 2024, I did hear some feedback from board members that maybe having meetings less frequently than monthly would be good. In other projects that I've been working on, specifically the webinars, it does appear that the lunch hour seems to work better for a lot of folks. And so with that information, I reached out to Chair Lawfridge and just discussing, hey, can we do every other month. Because we were able to schedule this meeting on a Wednesday, that's why it's a Wednesday. We don't have to stick with that, but the proposed schedule would be the first Wednesday of every month during the lunch hour. Those dates would include, obviously, today, April 2nd, 2025 at noon, June 4th, 2025 at noon, August 6th, 2025 at noon, October 1st, 2025 at noon, and December 3rd, 2025 at noon. So that is what is up for discussion. I'd like to open it up for board members. You know, if there's any feedback, times you can't make it, preferences, any ideas or thoughts on this?
Chris McCann here. Looks good on my schedule. I would make a motion that we accept this calendar for our meetings.
Thanks, Chris. Other comments from board members?
Dr. Rist, it's fine for me as well.
I'll take that as your second then for the motion. Just to move things. Okay, we have a motion for these dates. Be the first Wednesday of every month during the lunch hour, as indicated by Valerie. Any opposed? Hearing none, passes unanimously. Thank you. We will get that published also, so that, and Valerie will send out the invite so that we can get them populated on our calendars. Help with attendance. Okay, next will be item number 5, and that is to let's see, approve the Behavioral Health Policy Board's legislative priorities. And Valerie, I'm going to turn that over to you. We've had some work done on this in the past, and where do we need to take it going forward?
Fantastic. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. So with this, what I've done is I've taken the previous policy priorities and listed them out here with a summary of the different sub pieces. So the numbered items like 1, access to care, 2, insurance, those are the policy priority areas that you have previously decided upon. And then each of these has subcomponents. I believe it's 3 all the way through. And so what I'd like to do with this item, so long as it works for the board members, is I'd like to review these policy priorities, identify anything you'd like to change, if something needs to be added, deleted, or if you like it as is, then we can either approve as is, or amend it and then approve as amended. Does that work for the board members?
Works for me.
Okay, fantastic. So the previous policy priorities were 1, access to care, namely physical access, which includes transportation to and from intensive treatment as well as other treatment, proximity to care. As we know, the region that we serve is very broad and services can be very far apart. And then, of course, scheduling and whether or not those schedules are actually something that works for the patient and particularly meets their needs in the moment. Financial access, which includes insurance coverage, insurance type, because not all providers are able to take every type of insurance, ability of the patient to meet copays, purchasing fuel or to access services, and other supportive things like schedule interference with work and others. So for example, if someone works 8 to 5, but providers are only available in their community 8 to 5, Monday through Friday, that doesn't necessarily help them get access to care. Availability and capacity of services, so lack of providers of all types, but particularly those who can provide services for intensive care, co-occurring conditions, and or special populations, which would include serving youth and specific types of serious mental illness. Inability of providers to join insurance networks, even in documented provider shortage areas. Number 2 is insurance. And I'm just going to keep rolling unless somebody stops me. So board members, please feel free to jump in and stop me anytime. Insurance, limited coverage. So limited. Oh, yes.
Hi, it's Dr. Rist. just wondering, because I haven't looked all the way down, but do we capture somewhere licensing board issues that limit providers?
We haven't specifically named licensing boards. And that is something that we could do. I can't name specific bills because that I believe would be violating OML because it's statute, but there are bills that are active in the legislative session that would affect the autonomy of all of the licensing boards, particularly the four that we normally work with. So how those would be affected, or are they not? I'm not certain. We had put those under previous things under workforce development, so we could look at number and type. So, for example, proper resources must be allocated to support statewide efforts to educate and place providers in shortage areas. But we could also maybe look at resolving licensing board hiccups or inefficiencies.
That would be the appropriate spot to put that under workforce development, Valerie.
Okay.
Irrespective of what may be happening in the legislature this session, we need to continue that as our priority as we have in the past.
Okay, I will see if I can do track changes. Okay, so we're gonna go here. Let's see. So how did we want to word that potentially? Focus on resolving inefficiencies and challenges related to provider licensing.
Yeah, that sounds good.
And credentialing, licensing and credentialing.
Perfect. Okay. All right, so does that capture that?
Think so.
Okay. Okay, so going back up here to insurance, let's see, limited number of sessions with a provider covered, limited or lack of coverage for non-emergency, quote unquote, secure transportation or emergency transportation to services. Many intensive step-down services and non-state run inpatient facilities do not take fee-for-service Medicaid, which limits the number of spaces or beds available to care. Again, this is a previous thing. So on this particular note with the fee-for-service Medicaid, and Sarah, you may be able to provide further clarification on this. But it's my understanding that the bid has been open or applications have been open for different insurance agencies to apply to be the MCO for rural Nevada specifically. Sarah, do you have any insight on that?
This is Sarah Dubon for the record. So yes, I believe the RFP is out for for statewide MCOs. But for this specific bullet, many inpatient facilities weren't previously able to accept Medicaid fee-for-service because it wasn't a covered service. Now that we have the 1115 waiver in place, residential SUD treatment facilities can now be reimbursed through fee-for-service as well as managed care. Is that what this is getting at?
No, it was more the hiccup that I had found was that for some of the private inpatient mental health facilities, they did not accept fee-for-service Medicaid. And this also went for some programs that had, for example, virtual step-down services, so intensive outpatient treatment, that sort of thing, and we're able to offer it virtually. They were not accepting fee-for-service Medicaid.
I'm happy to look into that a bit more. I think with the 1115, now all private public facilities can reimburse for SUD treatment in these kind of intensive step-down facilities. But I'm happy to look into that more.
Okay. Yeah, because it wasn't necessarily on the SUD side. It was the mental health side that I'd been hearing was it was.
Okay, so Medicaid is prohibited from reimbursing, fee-for-service Medicaid, I should note, is prohibited from reimbursing in what's known as an institution for mental disease for psychiatric services, currently for the ages of 21 to 64. Medicaid has submitted an 1115 waiver amendment to request ability to reimburse for that from CMS, but that is still under review with CMS.
Okay.
So that would help in this area.
Okay. So then that being said, do we want to leave this as it is? Or are there any changes that we should make to that piece?
No, I don't know if it's, you can say development is underway. It's really, it's under review right now. So
Okay.
we've made some progress there, but it's still not approved.
Okay, so maybe it could be something along the lines of um
Valerie, I would just exercise caution in it's the board's priority to address these. There may be work already in progress.
Mhm.
We're hoping will come, but until it comes, it's still a priority of the board.
Okay. So how about support current and planned efforts to remove barriers to coverage for rural Medicaid rural patients who may be served by Medicaid. And then when it covers the fee for service, MCO, that whole thing. How does that sound?
That sounds good to me.
Any other board members?
Yeah, I think that sounds good. This is Matt.
Thank you, Matt. Hmm. Public payers. Okay, so for those who it's because I realize that might be a little bit small. Support current and planned efforts to remove barriers to care coverage for rural residents covered by public payers, including Medicaid. It doesn't need to be care coverage, it just needs to be care. Is that better? Remove barriers to care for rural residents covered by public payers, including Medicaid.
Looks good.
Okay.
This is Dr. Rist. I wonder, maybe we've not talked about this before, but I know an issue for providers has to do with prior authorization processes, both for inpatient services as well as for medication coverage. The procedure sometimes can be very onerous and can result in delay of patients getting needed services. So I don't know if we want to say anything about that.
Ooh. Yeah, I would think particularly when we're talking about crisis services, and having that covered. Can you elaborate on that a little bit?
Yeah, so I mean, I'm personally more familiar on the medication approval side. But very often you have a patient who's been stable for years on a particular set of medications, and then something changes with the insurance. And this this could be, it's not necessarily Medicaid, it's all insurance providers have their own processes. But then you end up, submitting a bunch of paperwork to try to get the medication approved. The insurance company comes back and says it's not approved on their formulary. You do this back and forth, and you have to request an appeal, and this happens frequently. And it's very, very time consuming and frustrating for both prescribers and patients. I think you might be muted, Valerie.
Sorry, thoughts from the board. My apologies. Do we want to add that?
I hear it. I'm just trying to synthesize it into a priority with a definition behind it. So we know what we're talking about. Is it improve the, insurance authorization process, or what is the actual ask that we're trying to make as a priority?
Okay. Insurance process red tape.
I mean, maybe something like reduce and streamline procedural barriers related to prior authorization for needed medications and services.
Okay, streamline of procedural barriers to patients receiving appropriate and timely care. Maybe?
Yeah, but it'd be nice to actually capture the term prior authorization, because that really is the issue.
Okay. Barriers to patients receiving.
Streamline of procedural barriers, comma, such as onerous prior authorization processes. And then the rest of what you had. For needed medication, treatments, and services.
Okay, so insurance process red tape, support and advocate for the reduction and streamlining of procedural barriers such as, why did it, there we go. My apologies. I don't know why I paused for some reason. Okay. Further reduction and streamlining of procedural barriers such as onerous prior authorization processes for appropriate and timely treatment and services.
I like that.
Okay. Other board members, thoughts? Unless anybody squawks at me, I'm going to go ahead and leave it in. Okay.
Move it along.
All right. Limited reimbursement for providers. Many insurance providers do not reimburse adequately for services, but most notably CMS Nevada Medicaid reimbursement is historically low. Sarah, I know that you mentioned that Medicaid's looking at improving that for at least some behavioral health services. Do you want to provide any insight on that?
So kind of like the first one, it is in development. These are really specific to behavioral outpatient treatment. I'm wondering if it's also possible to highlight somehow like advocacy around encouraging funding for higher rates of Medicaid reimbursement. Medicaid isn't able to raise rates on their own. We have to be provided the funding to do it. So I'm wondering if that's something we can highlight.
Okay, so then what if we add the board will support and advocate for efforts to improve reimbursement efforts underway and in the future?
I like that.
Okay, any other board members, any thoughts on that? All right. Barriers to in-network care, providers not being allowed to join insurance networks, which claim the networks are full, regardless of whether or not the provider will be serving a recognized provider shortage area. This is something I've heard across the board. Any thoughts or comments on that? Is this still accurate? Is this still appropriate? Okay, nobody's jumping up and down and yelling at me, so I'm gonna assume that we're okay with that. Number and type of providers available. So proper resources must be allocated to support statewide efforts to educate and place providers in shortage areas across the state. Focus on resolving inefficiencies and challenges related to provider licensing and credentialing. Training and best practices in telebehavioral health. Ensure providers who are working with clients via telehealth mechanisms are trained in best practices for telehealth treatment for behavioral health services. I know this is something that Be Here Nevada was going to work on when they get the capacity to do so. I believe Dr. Sarah Hunt and maybe another person from Be Here Nevada is on the call. I think I saw somebody pop in. For Chair Lawfridge, with your permission, I'd like to allow Dr. Sarah Hunt or another representative of Be Here to chime in if available on whether or not this is appropriate and they're able to do anything on this.
Yeah, I believe so, but it's still a priority of, we've heard from the constituency of our board.
Okay.
We want quality behavioral health. We want, it's about quality. It's not just the fact that you're delivering telehealth. It's what are the mechanisms and the best practices. So that's still a priority. So if there's other things being in the works, terrific.
Okay. All right. So then I'm hearing just leave this as is. Okay. Culturally competent, respectful, and age-appropriate practices. Providers in rural communities engage with people from diverse backgrounds, ethnicities, religions, and age groups. It is vital that these providers understand not only basic tenets of cultural competence, but also culturally respectful care and or age-appropriate care. Are we good with that as it is? Okay, I'm seeing some heads nod. All right. Quality of care, improved care transitions. Improve systems to ensure patients are connected to the care they need in a timely manner, regardless of who is staffed at various organizations. That's referring to some of the common practices in the region that we serve, but really statewide of, oh, I just have somebody's so-and-so's phone number. We go way back. I give them a call and they're able to place my patient, instead of everyone should be able to be on the same page with access. Improvements in discharge planning to protect the health, well-being, dignity, and continuation of care for patients when they're the most vulnerable. Improved communication among providers, need for HIPAA-compliant platforms used by all providers for the coordination of care. Increased use of business agreements or MOUs amongst various agencies and providers for specific coordination of care. Expansion of AOT and or ACT programs for persons needing intensive care in specific communities. Okay, any comments?
Valerie, I think when you use with the first time the AOT, ACT are used, it should be identified as what you're talking about there.
Okay,
The acronym.
I will go back and do that. I cannot remember the actual specific language on this.
If you could.
I want to say it's like assisted outpatient treatment. Dr. Rist, you would know.
Yeah, I think, again, I'm in the same boat, but I think it is assisted outpatient treatment, and then assertive community treatment.
Okay.
I
That
could be a little wrong on some of those words, so it's worth looking at.
And again, AOT is completely voluntary, whereas ACT is court mandated. Okay. Increase safeguards to care quality, supporting programs to evaluate and improve quality of service provision across the state, but most pointedly in the rural region. Okay, any other comments or changes there for quality of care? All right, and last but not least, we have collaboration and support for aligning or for supporting local efforts. A, collaboration and support for aligning efforts of local coalitions and agencies. The board will work to support and elevate the efforts of local and regional groups that are aligned with both the needs of the community and evidence-based or best practices. One of the things that we had done in 2024 for that was to keep an agenda item that allows for letters of support requests. Support best use of opioid settlement funds. The board will support local government efforts to use those funds in a way that both meets their intended purpose of addressing the opioid epidemic as well as meeting the needs of the community. Provide TA or connect a TA to local planning groups as able and appropriate. Expansion of local behavioral health task forces. The board directs the rural regional behavioral health coordinator to expand the establishment of county level behavioral health task forces across the rural region as communities are willing. And that is it for our previous priorities. Are there any changes, anything that you think should be removed, anything that you think should be added? Do we want to go with the amendments that are here in red?
Board members, this is your opportunity. Bueller? Bueller?
Dr. Riss, I like these priorities and I'd like to move to approve.
Yes, Matt, I'll second.
Awesome. Thank you both. We got that on record. Any opposed to these or additions that need to be made? Now's the time. Will be our 2025 priorities going forward that'll be published. Hearing none, I assume that it will pass unanimously then, and all the board that are present are agreed. If not, say so now. Okay, we got it. Thank you very much. Let's move on to number 6, Valerie. And that will be the discussion and possible creation of the legislative subcommittee for this policy board. We've done this in the past, just a little past history on this. We've done this in the past because things start happening as session goes into session. Things come fast and furious, and Valerie and I are left to try to keep y'all informed. In case there's something that comes up, we've entrusted that a subcommittee of members of this board could act on behalf of the board so that we can move things along and not get bogged down. Valerie, is there more that you want to add to that?
So just a couple changes, just to make sure that we're going in with OML. So previously we tried to have it a little bit more flexible. We need to have a formal list of members, and we do have to have a quorum of those members of the subcommittee in order for the meeting to move forward. So while I realize that this is probably one of the reasons why most of you agreed to participate in this board, or were voluntold for some of you to participate. We realize that you may not always have time to make all of meetings during the legislative session. And so we just want to be sure that if you do volunteer to participate in this, that you are really committing to try to make as many of the subcommittee meetings as possible, because we hate to have these meetings and the subcommittee and it isn't able to move forward. We should have an odd number because it makes it a little bit easier just to identify whether or not we have a quorum. Past session duties and scopes of this subcommittee were identifying opportunities and approving letters of support, neutrality, or in opposition of bills heard. That may be affected by your personal role, but it's really, and how you're funded, but really the board is wanting to speak to some of the issues. Working in cooperation with myself, the rural RBHC, to ensure local and regional stakeholders are aware of bills that may affect their operations and/or services. So if we see something that we know is going to affect, let's say, Chris was on this subcommittee last time, right? So let's say there's a bill that affects behavioral health and EMS. Chris would be our point person to help us get the information out there and get feedback from people in EMS about whether or not this is a good thing, bad thing, what the potential challenges are, etc. So that's an example. Providing testimony on behalf of the board on bills that may affect behavioral health services and/or programs in the region served by the board. Good news, they're keeping the opportunity to call in or provide testimony via Zoom. So you don't have to be present. I live 30 minutes outside of Carson, so I can be present with enough notice, enough being like, hour and a half or so I can get childcare. But I can definitely be there to support, but always hearing things from professionals and other members of the board is always good, particularly if it's something that affects the type of work you do within your professional role. And then any other duties that you as the board feel comfortable assigning to the legislative subcommittee. We can either determine the schedule here in this meeting, or the legislative subcommittee can identify a regular schedule upon its first meeting. Another thing that we should probably look into, and I don't think it's listed here, but would be reviewing and approving potential amendments to your bill, Senate Bill 68. So I'm going to put that here on the list as well. We do have the possibility of one friendly amendment from the Board of Examiners for Social Workers for the bill. We need to look into that a little bit further and make sure that everything kind of aligns with what other states are doing, and that it doesn't cause any issues. But that would be, for example, something that this subcommittee could do. I will go ahead and put this in track changes so that it's obvious to the public, because I did send this out before the meeting. I want to make sure that I can find ways to, oh shoot, it's not gonna let me do this. Okay. Review and okay, so board members, what are your thoughts? Is this something that you want to do? And if so, is anyone interested in participating? And is there any change in the proposed scope? So we did have Jerry and Chris, I believe, on our committee last time. Do you guys have any feedback or insight as to whether or not this is something that's useful?
Chris McCann here. I actually really enjoyed being on it last time. And it, at least for me, I felt like it gave us a great area to kind of discuss bills and bring some stuff back to the board in the more formal settings, and be able to just kind of tackle some of the things that were flying fast during the legislative session. So I thought it was beneficial.
Okay. Jerry?
I agree with Chris. It was beneficial. It was also, it kept you involved in the process. And I do think it's worth doing again. Unfortunately, I won't be able to volunteer this year because I've got some other things going on, but it is very beneficial for the board to know what's going on and to keep our fingers on what we need to keep our fingers on, if that makes sense.
Absolutely. I'm seeing some nods. Is there any board members who would be interested in participating? How about that? Let's see if there's anybody who can participate right now. We know there's a lot of things that are flying fast and furious. All right, we got Fergus. Anybody else? All right, so if nobody else is able to participate other than Fergus, this might be something that instead of having a legislative subcommittee, maybe if there's some way that we can move to designate the scope to Chair Fergus Loffridge. Would you feel comfortable with that? What is the thought? Because we don't have another meeting scheduled until the first week in April, which is right before first committee and first house passage.
Yeah, I'm on board with Fergus doing more work. This is Matt.
Thanks, Matt.
No problem.
Okay, so as I don't know that he can really ask for a motion on this because he would be directly involved. Are there any board members who would like to move to delegate these activities and authority to Chair Fergus Loffridge for the duration of the legislative session?
Chris McCann here. I'm going to give it a shot. I would move that we delegate these specific items out to Chair Fergus Loffridge during the legislative session. And I would add in there that he can work. We just went through our scope of focus for the year. It should be able to give him some good direction on feedback that we as a board would like to give to the legislative process. I'm open to any amendments if somebody thinks there's something needs changed on that.
Hey, this is Erica Rist. I feel bad that we're dumping this all on Fergus. Is there some way that we can add in that, he can reach out to us for support, like if he needs help with testifying or something like that, and some of us are available. I don't know quite how to frame that, but
Okay, so maybe with this second one or with this third one down, providing testimony on behalf of the board, providing testimony directly or finding appropriate speakers to include individual board members.
sure.
Okay, Chris, are you okay with that as an amendment?
Yeah, that works for me.
Okay. On behalf of the board on bills that may affect behavioral health services and or programs. Okay. All right, so we still have that motion. Do we have a second?
Valerie, the Chris McCann again, just kind of looking at that same talking point. I wonder if that's a place to put maybe some words related to within the scope of our priorities. I'm just thinking we went through and we've identified the things that we as a board really want to focus on, and like some of them are broad enough. I think that you'd be able take on a lot of talking points, but that might be a good spot to identify that we have our priorities and it should be there within those.
Okay, so I just added, all right, so I'm gonna put this in red. Okay. On behalf of the bills that may affect behavioral health services and or programs in the region served by the board and within the scope of the board's 2025 policy priorities.
I love it.
Okay.
I guess my other question on it would be for Fergus, does that seem appropriate enough or specific enough that you would feel comfortable being able to speak on behalf of the board with that direction?
Yeah, I've been silent in this, Chris, and I appreciate you asking. All of these things are what we tend to do now anyway.
Right.
So we're geared up for it between Valerie and I, and we can make it happen. Then we can come back and provide updates for you. We can't discuss things in the interim between meetings, but we can have it summarized so that when we do have meetings, we have to have discussions. There'll be a time allowed for that, as we're getting close to the time on today's meeting.
Yeah, I think what we can do is we can probably just hold maybe like a standing agenda item where Chair Loffridge gives an update on activities that he has performed on behalf of the board. How's that? So instead of having a meeting schedule during our regular meeting, so the next one being April 2nd, Chair Loffridge can give an update as far as things he's done on behalf of the board.
So just looking at the edit you made there in the membership section, do we want language in there so that if he does assign one of the board members to go and testify in a committee or something like that, do we want language in there to give him that latitude and know that we did?
I don't know that we need to, because the membership piece was really to make sure that we're not violating OML.
Yeah, okay. And that's kind of, I was thinking something similar. I just wanted to make sure that I was wrapping my head around it correctly.
Okay.
I'm going to echo what Jerry said too. I really did enjoy being on this last time. I do not have the bandwidth to be able to do it again this year. I was telling somebody earlier today, I feel like I'm drowning most days already. So, but I'd be happy to support and help where I can, Fergus. So.
Okay. All right. So I believe we still, Chris, does your motion still stand?
Yeah, and I would actually even simplify it now that my motion would be that we delegate this authority to Chair Fergus Loffridge and using the points that we've defined here.
This is Jerry. I'll second that.
All right. Chair, you have to call a vote.
Go ahead and call it. You're running it at this point.
All right, is anyone opposed? All right, motion passes unanimously. Thank you. So I believe that covers that. I will go ahead and stop sharing this. just going to go ahead and make sure that I have my report updated, my activity report updated, or available for sharing here. So I'm just going to hit some highlights. I did send this out to everyone. We haven't had a meeting since that October date, so it's been a hot minute. I want to go down here to CIT. We did have 14 people attend and complete the CIT. There were several different agencies represented. So we had Humboldt County Sheriff's Office, specifically their jail, Humboldt County Juvenile Services, Winnemucca PD, Elko County, or I'm sorry, Elko PD, not Elko County. My apologies. Esmeralda County Sheriff's Office sent someone, one of their 2 officers that they have had available at the time. So that was really cool. And we also had someone there from Community Chest in Mineral County. We had several speakers, the vast majority of whom were local, and I have to say they were some of the best presenters that I have seen in CIT. So hooray for the strength of the communities we serve. They were fantastic. I believe the only one who wasn't local, as far as the speakers, the individual module presenters, was Troy Stroman. I believe he was from Nevada Department of Veteran Services. And we use the 3 co-trainer model that is recommended now for best practices. We had Pam Coates there, who's retired law enforcement, to represent the law enforcement perspective. Laura Yanez from NAMI Western Nevada to represent the peer perspective. And then myself to really give more of like a policy overview. This seat is really supposed to be for a clinician, but we did not have a clinician available to really run the whole 40-hour thing. So hopefully someday down the road, we can have some clinicians trained as coordinators and trainers. That would be amazing, but couldn't do that and pull it together right there. Preliminary evaluation results. I held people's certificate of completion for the evaluation. Overall, the feedback was really good. We just need to look at maybe a different venue. The Winnemucca Convention Center was a little awkward with some issues with broken elevator, a blocked off stairwell that we were required to use outside that was also icy. So just some little things like that. I do also want to note that unfortunately, it looks like Nevada is not being funded for this next round of COSUP funding. So the COSUP funding in the previous round was used to expand most FAST and CIT in the northern region and also a little bit in the southern region. Unfortunately, they're not getting that funding again, so we need to look at other funding sources. But the good news is our partners have opened up those conversations and are already in better position to move forward with those projects if we are able to identify appropriate funding. Lots of legislative stuff going on. I do have a meeting with Senator Ellison, our new board member, tomorrow to get him up to speed as far as the board, and then also SB 68, your bill. There's currently no fiscal note attached. Let's see. It does not appear to be an issue for this bill regarding the other proposed legislation out there that may combine 4 or more of the licensing boards that affect behavioral health providers. So that should be okay. I have mixed feelings about that, but that's what it is. I'm also working on some 1-page summary documents for all of the regional behavioral health policy boards, and then another for specifically what is the Rural Regional Behavioral Health Policy Board, and then another for SB 68. So just some easy handouts that can be shared when people are like, what the heck board is this? Why are they around? As you may be aware, there is a bill in legislative session, I believe it's SB 78, that would remove or combine the Washoe and Northern boards and the Southern and Las Vegas board and Clark boards. Our region is not currently proposed to be affected, but that could have some major ramifications for our sister boards that have been very active. Haven't yet seen the bill drop that would split DHHS, as discussed in Governor Lombardo's State of the State address, but keeping an eye out for that. The governor's proposed budget that was released last month obviously had some major issues, and so it's my understanding that there are various agencies that are working to update, and there should be another budget proposed by the governor that is sent out soon. Real Health Day at the legislature is Monday, February 24th. And then Behavioral Health Day at the legislature is Tuesday, February 25th. And then what I've been spending the majority of my time on lately is the pre-legislative webinar series. We've had some really great feedback that it's something that people are enjoying. I did create a YouTube channel, so all of the recordings have been posted there. I'm also working on getting the board meetings that I still have recordings for uploaded there as well for people to review. Slide decks are posted on nvbh.org. So looking at the numbers, the highest attendance we had so far was with Stephanie Cook, who is the state's opioid treatment authority. With the current state programs regarding statewide substance use, statewide substance use and opioid systems, she had 92 attendees, 73 for federal funding, 62 for future state programs. We did start to get a little bit of a drop off in some of our participation. I think it was just one of those things where they're so close together. There's so many different opportunities. I'm glad they're being recorded. However, Elise Monroy's Advocacy 101 did have really good participation, as did her reading, understanding, and using state budgets for advocacy. The ones that are upcoming tomorrow, Dr. Sarah Hunt and Dr. Ashley Pruitt from Be Here NV will be discussing their projects related to behavioral health workforce development, and they'll be joined by Dr. Tara Rains from Children's Advocacy Alliance to talk about their efforts. On Monday the 10th, we've got Emma White from the Office of Suicide Prevention talking about state-level suicide prevention for youth. Then on Wednesday the 12th, Rachel Isherwood, who manages the build out and rollout of any changes to Nevada's crisis response system, will be talking about that update, what the timelines are looking like. Dr. Terry Kearns from the Office of the Attorney General will be doing a overview of the Surge 2024 annual report on Thursday the 13th. And last but not least, I managed to convince Ann Jensen from Nevada Medicaid to give an overview of the Nevada and DOJ agreement for the Children's Behavioral Health System transformation. That is the agreement with DOJ that has been in the news. So if you've been curious about that, that would be a really great opportunity there. I'm also been working with the state on the Bipartisan Safer Communities Act work. What they're doing is they're wanting to ensure that all local and state level emergency response plans include behavioral health considerations. So how are we going to follow up with people? How are we going to make sure that they have access to their medication, et cetera? I will be assisting Eureka County with the opioid needs assessment. Next meeting for that is on Friday the 14th. And it's our own Jerry Sanders and Dr. Amy Hines Sutherland from NACO who are leading that project. I'm going to be presenting at the Nevada Public Health Institute's Rural Public Health Summit on February 25th regarding behavioral health policy. And I do have access to a limited number of opioid overdose rescue kits from the OD2A program. So if you're interested, please reach out, let me know. These are things that are really made to be publicly available, maybe in an outdoor space where people can just grab them when they're needed, not something that we're necessarily keeping track of. Going down here, opportunities and suggestions. So I believe this might also be covered in some legislation. I've heard some rumors, but I don't have specific numbers, but opportunities for increased training for first responders and criminal justice personnel related to behavioral health programming for people in crisis. That seems to be a huge gap. The DOJ agreement with Nevada may produce a lot of opportunities for improvement and a focus on addressing that youth need, and maybe hopefully some money to shake loose for Be Here and other projects and programs that really can help bolster the workforce to meet that need. Because we've had some good success with the webinars, I think that utilizing the webinars to get information for broad audiences would be a great strategy instead of taking up time during board meetings. And something else that came from some conversations after the panel that we had with the chairs of the regional behavioral health policy boards and their coordinators. What if we did some sort of white paper where we brought everyone's priorities together? This is, access to care is on everybody's list. Transportation's on everybody's list. What does that look like at the federal level? What changes would need to be made? What are the changes at the state level, and what are some specific regional issues? And then are there evidence-based practices that match up with those? That would be a big project, but I think it really shows the need and kind of the focus of the boards. And the boards are particularly well poised to do that sort of thing because you are local level representatives. You do represent the professions and the regions that this board serves, as well as the others. And so it has a lot of voice in that. And since the Commission on Behavioral Health is on the chopping block with SB 78, you know, they would no longer be writing a letter to the governor if they went away to make recommendations. So having something like this to use as a template and work through may be nice if that comes to pass. So those are just some opportunities and suggestions. This is just an informational item, not a an action item. But does anybody have any thoughts on that or questions? All right, then I'm going to go ahead and yield the floor.
Let me get off of mute there. Okay, thanks Valerie for that. And no questions from the board. We have that as a was an addition to your meeting material, so look it over, identify those key dates in summary, and contact Valerie if you need more information. Valerie, do you know if the registration has gone out for the Rural Health Preparedness Summit?
So the Rural Public Health Summit that I'll be speaking at is on February 25th. I believe it has gone out already, but I will also send that out to my meeting list just so that you all have an opportunity to access that. Let's see. There is a preparedness summit, but I believe that is in September. So I think that would be a really good opportunity if there's some way that we can connect on that. And maybe have some opportunities to do some networking and some spitballing, so to speak, with some of our local level emergency managers. That might be good. Through the BSCA project, they're drafting the assessment. They're going to turn out the assessment to a small group of work group members, myself included, for review. And then from that assessment report, the state's going to build their project. So with that, I was talking to some of our state officers and asking them, hey, would it be something, could we maybe do some webinars on what are some considerations that for communities and emergency managers that have already done this? What are some lessons learned? Taylor Allison with Lyon County is kind of one of the only emergency managers that has a lot of experience with including behavioral health in response plans, as she came from the public health side originally and was also the chair for the Northern Board for quite some time. So that is something that we could definitely look into. Does that kind of answer your question?
That's the one off into the future. I was looking for registration for the one in February. I received a hold the date, but I have not received a registration for that.
Okay, I will send that out.
Let's get that out for folks. Okay, let's move then to public comment. Again, 3 minutes, and I will be timing at this point. Public comment. Anybody open for public comment? We've talked about a lot today. For folks subsequent, we had a lot on this agenda for today that we knew we were going to be tight on time. And I apologize for going over the amount of time that we have, because I like to keep these tight and respective of our board members' times and that of the audience. In the future, we will have a presentation, some update from Dr. Hunt and the Be Here Nevada work that's being done subsequent to our bill from last legislative session. Will also on the next agenda, next meeting in April, be talking about our legislative updates. So Those will be the key things coming forward, and we'll keep these concise and to the point and get the work done that needs to be done, and so that you can get back to your daily work. Again, I'll open it up for public comment if there's anyone that would like to have the floor at this time. I can't see
There's
those.
no, Chair Lawford, there's no hands raised.
Thank you. I can't see that part of it, so thank you. Then we will go for adjournment with the reminder that our next meeting will be April, what did we decide?
April 2nd. I know because it's my birthday.
April 2nd on Chris's birthday. Okay. At the lunchtime at noon. All right. With that, we'll call the meeting adjourned at 1:21 p.m. and thank you everybody for attending.